So this is the third case of septic arthritis. In this case, we will manage to detect any inflamed pelvic muscle on MRI scan. Okay, so here this is the anteroposterior pelvic radiograph. The first finding is widening of the symphysis pubis. As you can see here, there is widening of the symphysis pubis. Okay, so you need to know, widening of the joint space with effusion is a sign of early septic arthritis. Okay. The second sign is cortical or joint margin irregularity, indicating cortical erosion on both sides of the joint. Can you see this? Cortical margin irregularity. Okay. So cortical margin irregularity or cortical erosion, also a sign of early septic arthritis. However, subchondral, not cortical erosion, is a sign of late septic arthritis, and after bone destruction, you will find intra-articular bony fragment. Okay. The third sign is periarticular lucency or osteopenia. As you can see here, there is periarticular lucency or osteopenia, which is also a sign of early septic arthritis. Periarticular osteopenia or bone marrow edema. Bone marrow edema is seen on MRI. Periarticular osteopenia or decreased density of the bone on both sides of the joint is a sign of early septic arthritis. Okay, so the interpretation here, the findings will be suggestive of monoarticular. Also monoarticular involvement is a sign of septic arthritis. So the findings will be suggestive of monoarticular inflammatory process, okay, in the symphysis pubis, okay, along with the history of fever or an infective process or septic arthritis should be considered. As I mentioned before in the previous videos, okay, that if you see fluid inside the joint, okay, and the edema outside the joint, and only right-sided or left-sided affection, okay, so infection or septic arthritis should be considered, okay. However, inflammatory process as seronegative spondyloarthropathy is a differential diagnosis, okay. However, they are unlikely. Why? As they cause joint space narrowing with no intra-articular fluid. If this appearance is of inflammatory process, they will show joint space narrowing, not widening, and there will no be intra-articular fluid or effusion, okay. The management here at this stage before MRI, okay, should be or should include clinical and further radiological. Okay, this is the clinical, this is the further radiological. So I would correlate these radiological findings with the patient's history of either fever, infective endocarditis, or sickle cell anemia. Okay, and I would also recommend an MRI of the pubic bone to assess the degree of joint involvement as well as the involvement of the surroundings of tissue. Okay, so here you are the MRI imaging of the pubic bone. We try to make it okay. So before starting discussing the findings of the MRI, you need to know the anatomy of the pelvic muscles, okay? So you need to know the anatomy of the pelvic muscles on axial T1 and coronal T2 sequences, okay? So on axial imaging, this muscle is obturator internus. This muscle is obturator externus. These two muscles are adductor longus and adductor brevis. Adductor longus and adductor brevis. This muscle is pectineus muscle. Okay, obturator internus, externus, adductor brevis, adductor longus, pectineus. Okay, however, on coronal MRI, okay, obturator internus, here obturator internus, obturator externus, okay, adductor magnus, okay, adductor brevis, adductor longus, adductor brevis, adductor longus, adductor brevis, adductor longus, and here's the adductor magnus. It's deep to these muscles, okay, adductor magnus, brevis, longus. Okay, so this is the normal appearance of the muscles. As you can see, all the muscles are of the same intermediate signal intensity on T1 weighted images. Can you see this muscle? Can you see these muscles on coronal stair images? Yes. Can you see the signal? Can you see the signal? Yeah. Abnormal high signal intensity compared to the normal. Here, these are post-contrast T1 weighted images with fat suppression, okay? So here, this is the normal signal of the muscle of intermediate signal, okay? And this is the enhancing muscles, This is the normal muscle, and this is the enhancing or inflamed muscles, and this is the normal muscle enhancement. This is the hyper enhancing muscles, okay? So how to comment? So the findings on MRI are the following. The first one is there is widening of the symphysis pubis joint and associated intra-articular fluid signal, okay, low in T1 and high in stair. Yes, there is widening. There is widening of the symphysis pubis, okay, with fluid signal, low signal on T1 and high signal on stair, okay. So widening of the symphysis pubis with intra-articular fluid, okay. Next one, there is periarticular bone marrow edema seen within the pubic rami on both sides of the symphysis pubis joint, seen as abnormal high stair signal intensity. Okay, so this is the joint which is widened, and here is the pubic bone. Okay, can you see this abnormal signal? Abnormal high stair signal within the pubic bone. Okay, indicating periarticular bone marrow edema. Okay, so can you see this? This is the post-contrast enhancement of the pubic bone. Okay, indicating inflammation, bone marrow edema, and here with post-contrast enhancement on both sides of the joint of the pubic bone, on both sides of the joint. Yeah, it shows post-contrast enhancement. Which is the periarticular bone marrow. It shows post-contrast enhancement. The third finding, there is the adjacent muscles, the adjacent adductor as well as obturator muscles, okay, show a swelling, abnormal high stair signal, post-contrast enhancement. The adjacent obturator muscles, the obturator internus, obturator externus, okay, as well as the adductor muscles. Here is the adductor magnus and brevis, okay. So here this is the obturator internus muscle. This is the normal muscle. This is the inflamed muscle. The obturator internus, the obturator externus muscle, the obturator externus muscle, as well as the adductor magnus, the adductor magnus, okay, and the brevis, the adductor brevis, okay. These muscles, these adjacent muscles to the joint, show abnormal high stair signal, okay, as well as post-contrast enhancement. Can you see the post-contrast enhancement of the muscles? Yes. So this is the obturator internus, obturator externus, okay. Then the adductor brevis and the adductor longus. Obturator internus, externus, adductor brevis, adductor longus. Obturator internus, externus, adductor brevis, adductor longus. All of these muscles on both sides show post-contrast enhancement and abnormal high stair signal. Okay, along with enhancing soft tissue extension on the right side. Nothing here. Enhancing soft tissue extension on the right side, indicating phlegmon. Okay, so if you go to the previous slide, Adjacent muscle edema and phlegmon or abscess, okay, all are signs of early septic arthritis. However, abscess as well as adjacent muscle abscess or gangrene are signs of are signs of late septic arthritis. Okay. Okay, so here adjacent muscle edema, swelling, high stir signal, post contrast enhancement, as well as enhancing soft tissue extension, indicating phlegmon. All are signs of early septic arthritis. Okay. Interpretation. The findings would be suggestive of a monoarticular inflammatory process in the symphysis pubis joint with the history of either fever, infective endocarditis. So septic arthritis should be considered. The infective process should be considered here. Okay. However, the inflammatory process as seronegative spondyloarthritis is a differential diagnosis. However, the inflammatory process is unlikely here as they cause joint space narrowing, okay, with no intra-articular fluid nor adjacent myositis or abscess. Okay, the intra-articular fluid and the adjacent myositis or abscess is characteristic of septic arthritis and not seen in inflammatory arthritis. Also, after MRI images, you need to mention malignancy. Malignancy should be considered as a differential diagnosis, as Ewing sarcoma or lymphoma are differential diagnoses. However, they are unlikely. They are also unlikely as they don't involve the joint space. They don't involve the joint space. And on the opposite side, they tend to have extra osseous soft tissue extension. So the malignancy, okay, the malignancy don't involve the joint space and tend to extend outside the bone. Extra osseous soft tissue extension. The management after MRI, okay, diagnose and treat. Okay, diagnose and treat after MRI. No need for further imaging. So how to diagnose? I would recommend image guided aspiration of the symphysis, pubis, joint fluid, which is the gold standard, as I mentioned before in the previous video. Image guided aspiration of the joint fluid is the gold standard to diagnose septic arthritis, as it allows for culture and sensitivity, for culture guided intravenous for starting the intravenous antibiotic therapy. Okay, so this is how to diagnose. How to treat? Treatment is not your rule. However, you need to refer the patient for an orthopedic specialist to guide management, which may include intravenous and oral antibiotics. Intravenous and oral antibiotics, okay, as definitive treatment. This is the mainstay treatment, the antibiotics, as this is an infective process. The mainstay treatment is antibiotics, as well as symptomatic treatment by image-guided drain placement. placement, image-guided drain placement or surgical drainage of the abscess, okay? Okay, so this was the third case and how to detect the inflamed group of the pelvic muscle, okay, in a case of septic arthritis. So that's all, and thank you.